Today we are going to learn about the diffuse large B-cell lymphoma NOS category. So diffuse large B-cell lymphoma, the tumor is larger than the normal macrophage and more than or equal to 2 times the size of normal lymphocytes. Then there are several morphological variants and molecular subtypes which we will go into further detail. So DLBCL NOS morphological variants are centroplastic, immunoblastic, anaplastic and other rare variants. Molecular subtypes are GCB type and the ABC type. Then what are the tumors which are not common at DLBCL NOS? In that we have this list of large B-cell lymphomas. High-grade B-cell lymphoma and B-cell lymphoma unclassifiable. These are not considered in DLBCL NOS category. Then it is 25 to 35% of all NHL occurring in the 7th decade and more in the males. Etiology can be primary or it can be secondary. Secondary to CLL, SLL, follicular lymphoma, marginal zone or NLPHL. Underlying immunodeficiency is risk factor, EBV positive, more common in immunodeficient. ABC subtype is usually EBV positive. Then localization, it can be nodal or extranodal. This picture shows DLBCL NOS involved the spleen. Then this is a picture showing the DLBCL centroplastic variant. Then DLBCL centroplastic variant. This is DLBCL immunoblastic variant. CD20 positive. Then what are the other sites? It can occur in the GIT and several sites in the body. Then CNS, testis, skin, bone marrow. Bone marrow can be concordant or discordant involvement. Clinical features, it can be present as a mass, asymptomatic or with B symptoms. Microscopically you will have the 3 variants, centroplastic variant representing the centroblasts, mostly this GCP subtype. Then immunoblastic variant and the anaplastic variant. Then we also have some other rare morphological variants like myxoid stroma, papillary matrix, signet ring cell type and others. Immunophenotype, it should be positive for pan B cell markers. Then CD30 may be present in 10 to 20% of cases. EBV positivity can be seen. CD5 can be positive in DLBCL. And MYC and BCL2. BCL2 is seen in should be more than 50% to call it positive, and MYC should be more than 40% to call it positive. Then usually we have to follow the Hans algorithm. We have other markers, FOXP1, GCT1, LOMO2. Then KI67 is usually high. Cell of origin or the postulated normal counterpart, you have the GCP subtype and the ABC subtype. Then cell of origin subtyping is the 2 main molecular subgroups. But still you have about 10 to 15% which are unclassified. So if it is ABC subtype, you can add bortezomib to the R-CHOP therapy. In mutational landscape, we have the several mutations. Examples EZH2, GNA13 and several others. And several chromosomal translocations are also common. Then genetic susceptibility is seen in some individuals. Prognosis depends on the stage, clinical features, the stage and the age, and the IPI. Then the morphology. Immunoblastic is adverse. Then immunophenotype. CD5 has prognostic significance. BCL2, BCL6. or biomarkers. Then others, we have the CD30 expression is also important, Ki67. Then BCL2 is inferior, BCL6 is better. MYC translocation is inferior. Then others are also there, TP53, CDKN2A. Microenvironment also plays a role. Then we have the microRNA patterns are also important. Host genetics. Then therapy is R-CHOP.